Hello, guys. Welcome to MEDVERSE. And today we are going to discuss a very important topic that is rabies, which is from your PSM point of view. But as a doctor, also, you have to know what are the vaccines given, what are the doses, what are the regimens, modified thyroid cross regimen, okay, SN regimen, all of these regimens, which one we currently using. Okay, we will discuss from guidelines straight away. From guidelines, your park textbook has some mistakes in this topic because they are not updated with the recent guidelines. This guideline for rabies prophylaxis 2019 guidelines. Okay, these are the 2019 guidelines, which are the recent one. They don't update that frequently. So this is the most recent guideline of rabies which we are using nowadays, right? And we'll start from this guidelines and move ahead as we go. We'll discuss all of the things which are there in your PSM as well. Okay, so let's start. Uh, read the guidelines totally, so no confusion, no nothing to worry that this is not the updated one. This is the updated one. This is the recent one. Okay, when it changes, the guidelines will change, the regimens will change, everything will change. Right. From 2019, what we have? Let's read that. So you can just quote this as your standard text because this is the standard one. Okay, look at this. This page is not needed. I will highlight the important things. Okay, so rabies is basically transmitted by the saliva. Dogs are responsible for 95% of cases. You can see that Park textbook has used this guidelines as their reference. Okay, so percentages, values, these are standard ones, right? And cats 2%, by jackals, mongoose, and others 1%. Okay, these all bites transmit rabies. Okay, basically dog bite in India, but in West, bat bite is also considered. Okay, in West, bat bite, right? And rabies manifests as a hydrophobia. You must have seen that people start fearing water. So hydrophobia, thirst and fear of water, right? Same time, at thirst and fear of water, they fear water, but they are thirsty. Okay, so rabies is a very fatal disease. There's 100% CFR, that is case fatality rate. 100% case fatality rate is seen with rabies. Okay, so National Rabies Control Program, NRCP, we tell it NRCP, National Rabies Control Program, whose guidelines we are now discussing. Okay, key strategies: strengthening surveillance of animal bites and human rabies, strengthening lab diagnosis of rabies, increasing awareness of rabies in the community. Okay, all of this, I think, these are the statistical aspects, so you don't need to go into much detail, right? Let's discuss about the basics now. Post exposure prophylaxis. Uh, well, two terms: pre exposure and post exposure. So, exposure is basically disease or the bite. Post exposure means after the bite. What are the prophylaxis after bite? After bite is the post exposure, right? So, what post exposure prophylaxis need to be considered in following conditions? In which conditions you have to give post exposure prophylaxis? Bite by all warm blooded animals. This is a recent guideline: all warm blooded animals, not cold blooded, right? So, this can be asked in an MCQ as a statement based question. Exposure to wild animals. All wild animal bites should be treated as category 3 bites. All wild animal bites should be treated as category 3 bites. Just a minute. So are you understanding? Category 3 bite means category 1 is just licking the skin or mucosa, no contact with the inner tissues, right? Category 2 is a bite with no blood oozing, oozing. And category 3 is a severe bite, is a bite with blood oozing or exposure to wild animals. This is also treated as category 3 exposure and category 3 bite. Category 1, we only need soap and water, nothing else to be done. Category 2, we have to give anti-rabies vaccine. Okay, and category 3, we have to give anti-rabies vaccine as well as immunoglobulins. We'll see in detail, don't worry. Rodent bites. Exposure to domestic rodents, hare and rabbits do not require PEP. This is important. Domestic rodents, hare and rabbits do not require PEP, but rodent bites in forest areas, that is, if the rodent is a wild rodent. So wild rodent requires the post-exposure prophylaxis, that is PEP, right? Exposure to bat. Bat rabies has been inconclusive in India, not being conclusively proven in India. So now exposure to bats do not warrant PEP. Okay. PEP is post-exposure prophylaxis. Don't get confused. Human to human transmission. Is it possible? Yes, it is possible. Is it possible? Yes, it is possible. But how? Practically or theoretically? Theoretically. Theoretically. It is possible only theoretically, nothing practically. This is possible. Okay, after this lecture, don't ask me for notes because it is just the guidelines. You can just download and annotate, right? No problem in that. Okay, it is possible, but only theoretically. Practically, it hasn't been seen. Okay, minimal, no well documented cases. Okay, due to this PEP is not required in this cases also. It's rare, so you do not have this possibility even, right? Okay. Observation. PEP should be started immediately after exposure. Immediately. Post exposure prophylaxis, don't wait. Just give it the vaccine. Okay. You don't have to take the risks. Okay. Observation period is 10 days. Observation period is 10 days. Remember, in previous times, what we did was we give the PEP and observe the dog or cat for 10 days. Okay. In previous guidelines, we observe the dog and cat for 10 days. If he or she, whatever it is, if he or she seems rabid, okay, then we have to give the vaccine. And like that, conditions were there. But now this is not applicable. This observation period is now not applicable at all. You have to give vaccine irrespective of what. Okay. Look at this. If it is modified, if suspected cat or dog is healthy after 10 days, PEP can be converted to pre-exposure prophylaxis, skipping the vaccine dose and administering it on 28 using IM regimen. Okay. These all things are there. But this is there, but this is not practically applicable now. You have to give the vaccine. You don't need to take the risk. You don't need to run behind a dog or cat and observe if it is rabid or not. Okay, don't do that. Just give the vaccine, send the patient home. Done. Okay. Vaccination status of biting animals. These are things are there. Okay, look at this. Here it is also written. Previously this was the guideline, but this is obsolete now. Okay, after 2019, many years have passed, and now we are in an advanced stage. So animals vaccinated against rabies do not suffer and transmit the disease. However, animal vaccine failures may occur, inadequate doses, poor quality, or poor health status of the animal. So it is saying that if your animal is vaccinated, even if your animal, if you have kept a pet dog, even if the animal is vaccinated, when the animal is vaccinated, you have to give ARV. If he bites, you have to give the ARV because animal vaccines, the vaccinated animal may not respond to that vaccine which he or she has taken, which it has taken. Let's use it word for animals. Okay, so animal vaccine failures are very common. So you don't really know that if the dog or cat is fully protected against rabies or not. And once rabies sets, there is 100% CFR. So will you want to take the risk of determining if the animal is correctly vaccinated or not rather than saving the patient? No. Yes. I hope you understood. Irrespective, this line is important. Irrespective of vaccination status of biting animal, PEP should be given. Irrespective of vaccination status of animal, PEP should be given. At what cost? Provoked versus unprovoked bite. Provoked animal doesn't mean animal is rabid. If an animal is provoked, it throws stones at the dog comes to bite. This is a provoked animal. It doesn't mean that it is rabid. But a provoked dog bite should be managed as exposure and PEP should be started immediately. Okay. Whatever it is provoked, unprovoked. Okay, nothing to worry. Just you start PEP. Contraindications and precautions. Rabies is 100% fatal disease. Do you think that we should be skipping post-exposure or rabies vaccine in some cases? No. So 100% fatal disease, no contraindication to PEP. Nothing, pregnancy, lactation, old age, any illness, immunocompromised, anything to give the vaccine. Okay, no matter what. Doesn't have any adverse effect on pregnant women. It is pregnancy safe, lactating women, pregnancy safe. Okay. Okay, this is the important thing. People taking chloroquine for malaria treatment or prophylaxis may have a reduced response to intradermal vaccines. So you must have an idea that rabies vaccine may be intradermal or intramuscular. Okay, intradermal and intramuscular route. So it is telling that whoever is taking chloroquine for malaria treatment or prophylaxis, chloroquine. So whenever you are a patient with chloroquine, you just ask the history. So there is a decreased response to the intradermal vaccine. So he or she should get the IM vaccine. Okay, just this thing is written. With all vaccinated person, there must be an observation period of 15 to 20 minutes following vaccination. You have to keep under observation for 15 to 20 minutes. Okay. Rabies is a very long and variable incubation period, which may from 9 days to 90 days. Okay. This is given in some textbooks. Okay. No, nothing to that. Remember like that. Okay. Risk assessment of potential rabies can be complex and confusing. It should be considered at ARC, anti-rabies clinic. No problem. Let's discuss about the types of bite, category of exposure. Category 1, touching or feeding of animals. Okay, if you touch an animal or feed an animal, this is also category 1 bite. Remember, okay, this is a very you know different type of thing. Licks on intact skin. If the animal licks you on intact skin, there is no breach in the skin continuity. If it is contact with intact skin, secretions or excretions, okay, salivary secretions, excretions, feces, urine of anything of animals, then it should be category 1 bite. What you have to do? Wash exposed area with soap and water and apply antiseptic. Okay, you have to wash under running water. Okay, this water is running water. That's good. You have to wash under running water. You have to wash for 10 to 15 minutes. 10 to 15 minutes. Single best answer is 15 minutes. You have to wash, right? Okay. Second, nibbling of uncovered skin. Nibbling of uncovered skin or minor scratches or abrasions without bleeding. Okay, category 2. Category 1 is only licking, touching. There is an intact skin. Here there is scratches, and bleeding is absent. This is important. If there is a little bit of bleeding, even it will be considered under category 3. Bleeding is absent. You have to what you have to do? Wound management and rabies vaccine. You have to wash the wound, wash under running water, wash under soap, and you have to give the ARV, anti-rabies vaccine. Right? Category 3. Here there is bleeding. If there is multiple transdermal bites. Look at this, multiple bites. Okay, multiple bites. Licks on broken skin. If you have a wound and the dog or cat licks on that, there will be category 3 bite. I remember a case in which a um, like little boy of 5 year old, he had a pet dog, and usually what he did, if he had a wound, then he would make the dog lick the wound so as to clean the wound like that, or something like that. We don't know the child psychology or something like that. Okay, so he suffered from rabies and died. So that's the case. Contamination of mucous membrane with saliva. Okay, contamination with mucous membrane with saliva. This is also category 3 bite. We have to do wound management, rabies immunoglobulin, and rabies vaccine. You have to give immunoglobulin as well as rabies vaccine. We'll go give H-Rig, E-Rig, and all that, and rabies vaccine we'll discuss. Bite with wild animals and forest areas should be considered category 3. I told you earlier. Approach. What is the approach? PEP is a prolonged approach. Okay. Have to give wound management, passive immunization with rabies immunoglobulin. Rabies immunoglobulin is a passive immunization. Active immunization with anti-rabies vaccine, that is the rabies vaccine. Okay, we have to do this. Wound toilet. What do you mean by wound toilet? Means we have to manage the wound. So wound toilets are created. Wound toilet just means a basin, nothing else. That terminology. Okay. Immediately you have to wash the wound. So flushing and washing all wounds with soap and water, and application of povidone iodine as antiseptic. Povidone iodine antiseptic having virucidal activity. Any antiseptic having virucidal activity. Okay. 15 minutes should be the time you have to wash. And even if the patient reports late, you have to wash the wound. Okay. Do's. Wash all wounds with running water. Don't use stagnant water. Wash with antiseptic. Wash with water, soap and water, and apply antiseptic. Okay. This running water will remove mechanically all the virus from the wound. This antiseptic will inactivate the virus. Okay. Infiltrate immunoglobulin into depth around the wound in category 3 exposure. In category 3, we give immunoglobulins around the wound. Okay. This will neutralize the virus. Okay. Inactivation, neutralization, and mechanical removal of virus. Okay. Don't touch wound with bare hands. Don't apply anything like haldi chalk, something like that. Don't apply it. Okay. Immediate washing of hand is a priority. Immediate washing is the priority. Application of antiseptic, you can use anything, povidone, iodine, alcohol based hand that virucidal agent, anything you have to do. Suturing of wound. Suturing should be avoided. Suturing should be avoided. Avoided. Okay. Suturing should be avoided, delayed. Even if the wound is very large, even if the wound is very large and you have to suture to infect to you know prevent further infections, then you have to do, if we have to do loose suturing, you do loose suturing. Okay, have to do loose suturing. An infected bite is not a contraindication of rig infection. You have to give it rig. Rig is immunoglobulin basically. Okay, have to give rig in your infected bites also. Okay, and tetanus prophylaxis should be given. Okay, you can't just delay tetanus prophylaxis. Okay, tetanus must be given. Counseling of animal or dog bite vaccine. Okay, so most important thing is that a rabies vaccine is in fear. Okay, so you have to reassure. You have to reassure. This is compulsory. Even if you're doing medical management very finely, the person suffers from fear. The person suffers from fear, hydrophobia. So you have to counsel him. Okay. And importance of vaccine and timely completion of post-exposure prophylaxis is important. You have to counsel the vaccine. Rabies immunoglobulin, passive immunity. Okay. This is the thing. Indications in which cases rabies immunoglobulin is given. Category 3 and exposure to wild animals. Okay. Look at this. This line is very, very important. In immunocompromised individuals such as HIV/AIDS patient on immunosuppressive therapy, patient taking steroids, chemo, cancer patients having some immunodeficiency disorders, congenital agammaglobulinemia, in which the antibody titers are very less. The immunity is very slow. In which immunity is very less. You have to give immunoglobulin in category 2 and 3. So in two only we weren't giving the immunoglobulins, but here in which the immunity is very slow, we have to give immunoglobulins category 2 as well as category 3. Okay. Two type of rigs are available, that is immunoglobulins are available. One is the equine rig, equine rabies immunoglobulin, E-rig. Okay. E-rig is a heterologous origin. What you did is you inject the horse with the rabies virus, and the antibodies you get from the horse, you process it and make it a immunoglobulin. Okay. So manufacture purified FAV fragments, and this occurrence of adverse events has been reduced here in the E-rig. Okay, they are produced in Indian public and private sectors. Currently available, they are E-rig are available. Heterologous origin, small risk of anaphylactoid reaction. You have to keep the patient under observation. Okay, this is a 1 in 1.5 lakhs chances of your anaphylactoid reaction, and skin test is not much needed because it is a very uh, you know remote risk of having a anaphylaxis from E-rig. Okay, but you have to know the anaphylaxis management as well. Okay, you have to keep ready all the things for emergency cases. Then HRIG is the human rabies immunoglobulin. It's of homologous origin and free from, just a minute. Okay, so we are here. I was talking that this HRIG is the human rabies immunoglobulin. This is a homologous origin. Heterologous was of horse. So nowadays it is available. E-rig is available, but HRIG is better than E-rig. HRIG is better than E-rig because there is no anaphylactoid reaction. HRIG is given half the dose of E-rig. E-rig was given 40. Okay, HRIG is 20. But 40, ERIG is 40 international unit per kg body weight. Per kg body weight, you have to calculate the dose accordingly. HRIG is 20 international unit per kg body weight. 20 international units per kg body weight. Okay, understood everything? Yes. Administration of RIG. How you have to administer the RIG? Let's read. RIG should be brought to room temperature before administering the patient. It should be given the room temperature. Role of RIG is to neutralize the antibodies. It is administered only once, preferably as fast as possible after initiation of post-exposure prophylaxis. Okay. First dose, you give the first dose of rabies vaccine. RIG should be given within 7 days of administration of rabies vaccine. This is important. It is not indicated beyond seventh day after first dose of rabies vaccine, regardless if it is taken in 3 or 7, nothing. It will represent a wastage of RIG. Okay. If you are giving beyond the 7 days, then it will be considered wastage of RIG. Okay. So maximum dose of HRIG is 20 international per kg body weight. ERIG is 40 international unit per kg body weight. So human RIG is basically given less. Okay. It should be infiltrated carefully into or as close as possible to the wound or exposure site. It should be administered as close to the bite site or around the wound. If you infiltrate around the wound, is better. Okay. So infiltrated carefully into or close to the wound or exposure site, it should be administered close. Evidence suggests that injecting the remaining RIG volume intramuscularly at a distance from the wound provides little or no protection against rabies as compared to infiltration of wound alone. So this is very, very important. Earlier you used to tell that whenever the RIG remains, there is a remaining RIG, you administer it far away in the buttocks, in the thighs, everywhere. Okay. If there is a bite here or here, you are administering in the thigh. Now study says that if you are administering at the intramuscular site, you know, at a distance from the bite, then it provides no help. You have to administer it close to the wound. Okay. Small wound, there is a high likelihood that there are additional small wounds. If a child does not report all wounds, there is a small wound, there may be small wound. Okay, here there was a bite, and here also there is a scratch or something like that, wound. Injection of remaining RIG intramuscularly as close to the possible to the presumed exposure site to the degree that is anatomically feasible is indicated. That is the same thing, you have to administer close, at the closest distance from the wound. Okay. Tip of finger to earlobe or bites on the nose or around the eye can be safely injected with RIG. Okay, you have to give, but be very careful because these are delicate organs. So you have to be very careful when you are administering RIG to these parts. It can be administered. Okay, it can cause compression syndrome. Okay, it can cause compression syndrome. RIG should be never be administered in the same syringe or same site where the vaccine was administered. Okay, so you have to give RIG and vaccine in different injections, in different syringe and different sites. Okay, this is important, or else it will cause, if not, there will be compression syndrome. If not, there will be compression syndrome. And 15 to 20 minutes observation, I told you. RIG must never be given intravenous. Anaphylactic reaction are rare, but you should not give RIG intravenously. You always have to give RIG intramuscularly. Okay, serum sickness is another side effect of RIG. It is rare and occurs usually after 7 to 10 days. Okay, with E-RIG, but H-RIG no such problems, right? This is the thing. Rabies vaccine. Okay, rabies vaccine. Rabies vaccine. This is the thing. Indications. What are the indications? All animal bites category 2 and 3 exposures, irrespective of the age, body weight, anything, you have to give rabies vaccine. Okay, what are the stories? So most are marketed in freeze-dry lyophilized form. It is recommended that this vaccine should be kept and transported temperature range of 2 to 8 degree and protected from sunlight 2 to 8 degree and protected from sunlight, right? Freezing doesn't damage the vaccine, but there are chances of ampule breaking. Okay, so this is the ideal condition. Ideal condition is basically, I'm writing ideal. Ideal condition is basically 2 to 8 degrees Celsius and sunlight protected. And sunlight protected. This is the ideal condition in which rabies vaccine must be kept. Lyophilized vaccine, that is freeze dried vaccine basically should be reconstituted. This lyophilized vaccine should be reconstituted with a diluent, okay, immediately after use. So if you are freeze drying the vaccine, if it is a lyophilized form, then you have to add the diluent and reconstitute it. Okay, some have diluent 0.5 ml, while other have 1 ml. As per the diluent, you have to reconstitute it. Okay, and after reconstitution, you have to use immediately within 6 hours. Immediately within 6 hours after reconstitution, you have to use immediately after 6 hours. Okay, if it is a delay 6 hours, it's just a after 6 hours it is not used. Okay, you have to give rapidly. Okay, you have to give immediately after reconstitution, but if there is a delay, then you can delay it for 6 hours at max. Okay, so this is the thing. And adverse effects. So these are least reactogenic vaccines basically. Okay, these are you know okay, yeah. So what we are taking, we are telling that these are least reactogenic vaccines. Basically, this cell culture derived vaccines, which are least reactogenic vaccines. Mild adverse effects may follow. Mild anaphylactic reactions may occur. Headache, malaise, nausea, fever. This may occur after vaccination. You have to reassure the patient that it's normal. It's nothing that problem. It is erythema, pain, or swelling may occur at the sites, or allergic or neurological side effects are noted in very, very, very rare cases. Okay. Okay. Shifting from one brand to another brand should not be encouraged. Okay. Only one brand. If you take a 0 dose at other brand, third dose, any other brand, seventh dose, yet other brand. Okay. So it will be problematic for you. Okay. These are not important. Mechanism is not important that much. Okay, let's discuss the mechanism of immune response. If you have to write, then this is not much important. When given by IM route, it's basically deposited in the muscle. Okay, from the muscle, it is absorbed from the blood vessels and presented to the antigen presenting cells. This antigen presenting cells basically uh, present the antigen, trigger immune response. And we are giving ID, intradermal route. Vaccine is deposited in the dermis at one or more site. Okay, and this from the dermis are carried away by antigen presenting cells to the lymph nodes, and this will uh, you know elicit a immune response in. Okay, immune response induced by ID is comparable to IM, so no much difference. If you are giving ID or IM, it's fine. Route of administration: rabies vaccine can be administered intradermal or intramuscular route. Okay, so DCGI has approved it, and this is administered intradermal route. Okay, intradermal route. National Rabies Control Program strongly advocates use of intradermal route. Strongly advocates use of intradermal route. So whenever you are going to an anti-rabies clinic, you must have observed that there is a bleb formation there. Okay, so intradermal route is widely used, widely used. Okay, intramuscular is very rare cases. Okay, for immunocompromised, you have to give in which route? Intramuscular route. Immunocompromised, you have to give by intramuscular route. Rest all you have to give by intradermal. Volume of ID route is lesser. So intradermal route is, very wherever there is a hospital or some setup like that, the intradermal route is preferred because less dose you have to give, less volume you have to give. There is a ease of giving. IM injections are painful. ID is not that painful. Okay, you have to see that this potency and all are not required. Okay. Regimen for post-exposure prophylaxis, updated Thai Red Cross schedule. This is important, the most important part of this chapter. Updated Thai Red Cross schedule 22202. Updated Thai Red Cross regimen, that is 22202. Okay, this is the regimen which you have to understand. Okay, so what we have to understand is we have to understand and learn the modified Thai Red Cross regimen. Okay, the modified Thai Red Cross regimen, which is the correct regimen, is the updated correct regimen for vaccination of rabies vaccine. Okay, so starting with the modified Thai Red Cross regimen, look at this regimen. Here we write this regimen as 22202. What do you mean by 22202? 0, 3, 7, 14, 28. These are the days where we previously gave vaccine. Okay, but now this 14th day is not given. 14th day vaccine is not given. So two vaccines on 0th day. 0 day is the day in which the first vaccine dose is administered. It is not the day of the dog bite. Understood? Okay. Two vaccine, two vaccine on third, two on seventh. This is a post exposure. Just pay attention. This is, I am not talking about pre exposure. Pre exposure or re exposure, these are all different, right? This is post exposure. PEP, I am talking about PEP. Two doses, two vaccines on day two, two on three, two on seven, and 0 on 14, and two vaccines on 28. So, two vaccines, I mean one vaccine of 0.1 ml on each deltoid. 0.1 ml vaccine on each deltoid must be given, right? Look at this 0, 3, 7, and 28. Okay. Injection of 0.1 ml reconstituted vaccine per ID site on two sites per visit. Okay. So, this is ID regimen, one on each deltoid area. Okay. Understood? This is the modified Thai Red Cross regimen. We'll discuss pre-exposure and re-exposure. Sorry, when it comes into our topic. Okay. So starting with it, let's discuss the maintenance of vaccine vial. Okay. Use it aseptic technique to withdraw the vaccine. Store in refrigerator. I told you 2 to 8 degrees Celsius. Do not freeze the vaccine. Okay. Do not freeze the vaccine. Do not expose to sunlight. Use reconstituted vaccine as soon as possible, but within 6 hours if it is a delayed case. Material required. What is required? 2 milligram disposable syringe with 24 gauge needle for reconstitution. Disposable 1 ml insulin syringe with a fixed needle. Okay. This is used disinfectant swab for cleaning the top of vaccine vial and patient skin. Patient skin must be cleaned. ID injection technique. What is the injection technique? I am sure you must have learned giving the vaccines very intern. But let me tell you, using aseptic technique, reconstitute the vial with the diluent supplied by manufacturer. Okay. So in insertion of ID needle, you have to insert it just parallelly to the skin at a very less angle, and bleb on ID inoculation. This is the bleb formation. This is the bleb. So bleb formation indicates that the vaccination is successful. Okay, this bleb formation indicates that vaccination is successful. 1 ml syringe draw 2 ml 0.2 ml. Okay, uh, of vaccine needed for one patient. Okay, 0.2 ml. You take 0.2 ml, inject on 0.1 on and one deltoid, 0.1 on other deltoid. Right. Expel air bubbles. Don't leave any dead space in the syringe. Okay, like this. You have to stretch the surface of skin and insert the tip. Insert the tip, beveling. Upward. Okay, the bewailing must be upward, almost parallel to the skin surface. I told you almost parallel. Slowly inject half of the volume in the syringe. Okay, that is 1 ml, 4 units per 10 units. Okay, into the uppermost dermal layer over the deltoid, 1 inch above the insertion of deltoid muscle. 1 inch above the insertion of deltoid muscle, you have to give the vaccine, right? If needle is correctly placed inside dermis, resistance is felt while injecting the vaccine. You have to feel a resistance. If resistance is not felt, you will understand that the vaccine has entered deep. If it is entered deep, you have to give again. Okay. A raised bleb should begin to appear immediately, causing an orange peel appearance. That is PUD orange appearance. Don't confuse this PUD orange with the breast. Okay. Inject the remaining volume of vaccine, that is 0.1 ml again, on the opposite deltoid 1 inch over the deltoid insertion. So what is the site, what is the mode, what is the process, you understood from this. Okay. If it is injected too deeply in the skin, subcutaneous bleb was not seen. It should be withdrawn. Needle should be withdrawn and reinserted at adjacent site, and ID vaccine have to be given once more. Okay. If there is no bleb formation, you have to give the ID vaccine once more. Okay. If it is deltoid region cannot be used for injection, you have to give the subscapular or anterolateral thigh. So the most preferred is the deltoid, and the less preferred is the subscapular, sorry, suprascapular or anterolateral thigh. These are the sites in which the vaccine must be injected, right? Advice: do not rub the injection site, do not apply anything, complete the course of vaccination, on 0-3-7-28th day. Have to come and take the vaccines. So total how many doses? 8 doses. How many doses per day? 2 doses per day. How many days? 4 days you have to come. Right? So this is the regimen. Adverse reaction: mild itching, erythema, rarely body ache, fever may be there, usually self-limiting. If not, you have to prescribe analgesics and antihistaminics. So basically what we do is that for the patient, for the convenience of the patient, you usually prescribe the antihistaminics along with the vaccines. Okay. Okay. IM route. Intramuscular regimen for post-exposure prophylaxis, SN regimen. Okay, we discussed modified Thai Red Cross regimen. Now we'll discuss the IM regimen. IM regimen, that is the SN regimen. SN regimen. Okay, this is written 1-1-1-1-1. What is this? 5 dose intramuscular schedule. Okay, 5 dose intramuscular schedule. What days? 0, 3, 7, 14, 28. These are the days where you have to inject 1 dose of vaccine. Okay, and day 0 indicates the date the administration of first dose of the vaccine. Okay, day 0 is the administration of first dose. Okay, what is not recommended is that once you are starting ID regimen, don't switch to IM regimen, and once you are starting IM regimen, don't switch to ID regimen. The switching of route is not recommended. Sorry. Switching of route is not recommended. Okay. Site of injection. This is also deltoid. Same. Deltoid is ideal for administration of this vaccine. Gluteal region is not recommended because fat present retards the absorption of antigen and impairs the generation of an optimal immune response. Wherever there is more fat, we feel that it is easy to give the vaccine, but no, please give in deltoid region because once you give in it's high, there's a high fat. If you high fat, then absorption of the vaccine into the bloodstream is decreased. Due to this decreased absorption, there is a not a optimal immune response which you are expecting. Is not a expected immune response, right? But in infants and young children, anterolateral part of thigh is the preferred site. In infants, you have to prefer the anterolateral thigh. Anterolateral thigh is the preferred site in infants and young children. Infants and young children. Okay. So this is the SN regimen, 5 dose intramuscular regime, SN regime. Okay, 5 dose, 5 visits, 1 IM dose of vaccine on day 0, 3, 7, 14, 28. 0, 3, 7, 14, 28. Okay. So 0, 3, 7, 14, and 28. In your microbiology textbooks, these regimens are given incorrectly. So please follow this recent guidelines. Please follow this. Okay. And no teacher can contradict you if you are writing this because this you can quote is NRCP guidelines, NRCP 2019 guidelines. which I am telling is NRCP 2019 guidelines. This is the official PDF which is available from the MOF. Okay. So this is the SN regimen. So we discussed that there are two regimes you can say. One is the modified Thai Red Cross. One is the SN regime. Modified Thai Red Cross, I told you, is the intradermal regime. SN, I told you, is the intramuscular. Here we give 22202. Here there is 11111. This is given in 037 and 28 days. It is given in 037 14 28 days. Here it is given two injections on each deltoid. Here it is given one injection on each deltoid. One injection on each deltoid. Okay, this is the thing which you have to understand and remember. Okay, no confusions. Clear? Okay. People get confused in the rabies vaccine regimens, so please follow this lecture, and you don't need to have any sort of confusion in your mind. Okay. This is the this is the post exposure prophylaxis. Pay attention. This is a post exposure prophylaxis. Post exposure prophylaxis. This is not the pre exposure, re exposure, anything. It's a post exposure. Just remember, understand. Okay. Modified Thai SN regimen. This much is the summary. Vaccinated person, I told you 15 to 20 minutes for your follow. It is they are kept. Management of re-exposure in previously vaccinated individuals. Now we'll discuss the re-exposure prophylaxis. Means you a dog bites a person, then again after vaccination, what if the dog bites the person again? Not the same dog, obviously, any other dog. Okay. So re-exposure is basically who people who have taken previously the vaccines, right? Proper wound management should be done. There should be no compromisation in the wound management. There's no need of administration of rig. Rig is given only once. Okay. One site intradermal vaccine on day 0 and 3. If we have kept the vaccine, if we have kept the person on modified Thai Red Cross, modified Thai Red Cross regime. Okay. You have to give one site, only one site intradermal on day 0 and day 3. Okay, one side intradermal on day 0 and day 3. This is the re-exposure. Just a minute. Understood? This is the re-exposure prophylaxis. So if the dog bites again, then you have to give one side 0 and 3. If you have kept the person on intramuscular, you don't need to change the regimen. It's not like that they will be giving post-exposure other regimen, pre-exposure another regimen. It's not recommended. You have to give one side intramuscular administration of an entire vaccine vial on day 0 and day 3. So IM, SM regimen, you have to administer one side intramuscular on day 0 and day 3. And you have to inject the entire vial. Okay. Only adequate wound washing would be required in case of re-exposure where animal bite victim has documented proof of complete PEP or PRAP within last 3 months. So there is a twist in the story that if the person has taken the complete course of post-exposure within the last 3 months, then only you have to give the vaccine. Then only you have to give the vaccine. If he or she has taken the vaccine, let's say 3 months have passed. Let's say 3 months have passed. then you have to give the vaccine. If 3 months haven't passed yet, if 3 months haven't passed yet, you only wound washing, only wound management is required. Okay, just understand what I am telling you. If within the patient comes again after bite within 3 months, within 3 months, person comes to you again within 3 months of the previous bite, within 3 months of previous bite, and more than 3 months. If the person comes within 3 months of the previous bite, you don't need to give any vaccine. You just need to do wound management. Provided the person has completed all the vaccines, provided the person has completed all vaccination schedules, and more than 3 months, you have to start the vaccine. You have to keep the person on re-exposure prophylaxis, re-exposure prophylaxis. Okay, and this re-exposure prophylaxis, as I told you, that you have to give 2 doses on 0 and 3rd day, one site. You can do IED or IM, whatever. Okay, 2 doses if the patient is presenting to you more than 3 months. Understood? Very clear. Okay. Okay. People who have previously received full post-exposure treatment with neural tissue vaccine (NTV) or vaccine of unproven potency, or cannot document complete previous PEP or PRP treatment, should be treated as fresh case and given full PEP. Okay. So what I am telling is that people who have previously received full post-exposure treatment with neural tissue vaccine, this vaccine which we are using in SN and modified thyroid cross is basically the CCV, cell culture derived vaccine. But people who have taken previously post exposure with neural vaccine, or a vaccine of unproven potency. Let's say a person is of different country. Okay, a person is of different country. He or she is telling that I had taken some vaccine on some different days or so. There may be different regimes. There may be different vaccines in different countries. So, vaccine of unproven potency, or cannot document complete PEP or PRP treatment. Okay, or the patient is unable to convince you that he or she has taken the full course of PEP, then you have to treat as fresh case and give the full PEP. Okay, then I have to make the patient understand that, look, the vaccine which you are telling you have taken, or the schedule which you were supposed to take is not clear to us, and we can't take risks. So it's better if we start treating it as fresh case. So we will come at zero, the depending upon the regimen, modified thyroid first, then 07 for 037 28 days. Okay, and to give us fresh case. Rabies PEP with immunocompromised individuals. Immunodeficiency diseases like HIV/AIDS patients on steroids, chemotherapy, cancer patients, HIV/AIDS. Okay, they have basically very less antibodies. So, immunological memory is not assured to you that the vaccine will fully protect you against rabies. So, proper wound management followed by local infiltration of rig in both, this is important, in both the category 2 and category 3 exposure. Proper wound management must be done with local infiltration of rig. Rig must be infiltrated locally, and category 2 and category 3 must be that rabies vaccine is given by IM route. Okay, in both category 2 and category 3. Okay, so IM vaccine is preferred. Understood? Pre-exposure prophylaxis. Pre-exposure, that is before any bite. Before any bite. This is not required for all people. Some high risk groups are there. or pre-exposure prophylaxis. Laboratory staff handling the virus and infected material, and clinicians and individuals attending to the human rabies cases. Okay, let's say a technician or a lab technician or a nurse is constantly giving the vaccines to the people, okay, or handling rabies cases, or if a clinician is posted in ARV, okay, or laboratory staff who are handling the virus, okay, veterinarians, animal handlers, and dog catchers were constantly exposed to the virus, maybe possibility of transmission of rabies may be there. Wildlife wardens, quarantine officers, travelers from rabies free area to rabies endemic area, for example India, so people coming from foreign to India, okay, like that. So Indian Association of Pediatrics has recommended pre-exposure prophylaxis of children, okay. So for pre-exposure prophylaxis, total 3 doses are recommended. IM, one full vial to be given on 0 and 7, and booster on 21 or 28. Okay, booster on either day 21 or 28. 21 or 28. This is the pre-exposure. In case of ID route, 1 ml on each side to be given on day 0 and 7, and booster on either day 21 or 28. Day 21 or 28. Okay, so what we understood is was if it is a, let's write here, if it is a pre-exposure prophylaxis, pre-exposure prophylaxis. So what we have to do is that either you can use IT or IM. If you're using IM, you have to give one full vial for giving IT and 0.1 ml, and both are given on single site, on which 3 doses must be given. 3 doses on 0, 7. This is also 0, 7, and 21 or 28. Any day is preferable. 0, 7, 21 or 28, 0, 7, 21 or 28. You have to give the vaccine. Okay? Just a minute. Understood, right? Done. So 0, 7, 21 or 28. Here also 0, 7, 21 or 28. You have to give the vaccine on this days, and this is about the pre-exposure prophylaxis. Okay? Deviations in PAP schedule. Uh, So there are some deviations. One or two deviations do not necessitate restarting a vaccination schedule. If the person is coming 1 or 2 days later or 1 or 2 days early, then you don't. There's much delays, right? People in India usually are fond of delays. I don't know why. So two or one or 2 day deviation do not necessitate a restarting of schedule. You can just give. In instances where patient fails to visit on the scheduled date of first 3 doses and misses one or more dose, administration of additional doses should be considered to complete the vaccination. Okay, if the patient has been missing a dose, then you can use additional doses. Okay, because it is rabies, you can take risk, right? Okay, newer advancements. So WHO is currently, this is a new topic, so not much important. Just new developments are there in subsequent editions of this NRCP guidelines. Okay, rabies prophylaxis guidelines, 2019. After the recent guidelines, maybe some other guidelines regarding monoclonal antibody use as a cocktail, containing at least 2 monoclonal antibodies against rabies virus. Okay, as an alternative for rig. Okay, so maybe in future this rigs may be replaced by a cocktail. What is a cocktail? Cocktail is a combination of two or more than two antibodies which are of monoclonal origin. Monoclonal origin. Okay. They are being licensed by DCGI in current this thing. Okay. And this is study. So let's look at the summary very clearly given in your national guidelines. So people who are, I want to make you understand that be ahead of textbooks which you are following, and try to read information from this you know genuine guidelines. Okay, you have to read the genuine guidelines for us to give a complete source of treatment, and you don't need to have defenses in your favor that They are not the standard treatment guidelines. You can't say that this or that textbook has written like this or that, so I had given like this. You can't justify that. If you are saying that it is written in the National Rabies Control Rabies Prophylaxis Guidelines 2019, then you have a genuine source of information. Trust me. Okay. Okay. Let's read the summary. What is given in your guidelines? So post-exposure, I told you, post-exposure, intradermal and intramuscular. Intradermal, I told you, is the modified high red cross. Intramuscular, I told you, is the SN. Here you have to give 0.1 ml per dose. Here one entire vial. What are the doses? This SN regimen was H22202. So day 0, 3, 7, 28. Number of injections? 2 per dose. Okay. Two injections. And number of visit, 4 visits. 4 visits. Person has to visit on 0, 3, 7, and 28 day, and where you have to give deltoid muscle. In infants, anterolateral thigh may be preferred. Will you prefer buttocks? No. Pre-exposure. Okay, intramuscular. Intramuscular, one entire vial on 0, 3, 7, 14, 28. So this is 1 dose on each deltoid. One dose on each deltoid. And here patient has to visit 5 times. So in immunocompromised, you will prefer your intramuscular regimen. Then pre-exposure. Pre-exposure means intradermal, intramuscular, anything can be there. Intradermal, or you can give intramuscular. 0.1 ml per dose on 0, 7, 21 or 28. So this is 0, 7, 21 or 28. Patient will be given 1 dose per day, 1 dose per day, and patient has to visit 3 times. And intramuscular, one entire vial you have to inject on 0, 7, 21 or 28. This is again 0, 7, 21 or 28. 1 dose per day, and person has to visit 3 times. And re-exposure, okay, again re-exposure, intradermal, intramuscular. Here intradermal 0.1 ml per dose. Here entire vial 0 and 3, only 0 and 3, and here also 0 and 3. Okay, and 1 dose per day. This is also 1 dose per day. So re-exposure basically of 3 doses. This is of 3 doses. Okay, and here 2 and 2. Basically, these are the number of visits, and the sites remain same for all the vaccinations. And is re-exposure valid for less than 3 months? Less than 3 months, you have to, what do you have to do? Less than 3 months, you have to only do wound management. And if it is more than 3 months, then re-exposure. If vaccine is of unknown potency or any other type of schedule, other vaccine may be not be efficacious, or if the patient cannot convince you that he or she has taken, you know, what you can say, that he or she is not able to show that the schedule is complete, then you have to start as fresh case, right? Annexures. Let's look at the annexures. What are there? Okay, these are the anti-rabies vaccines. What are the vials which are available by which companies? Don't need to look at this. Equine rabies, ERIG are also available here, and these things are given. Human rabies immunoglobulins. These are HRIG are by Bharat Serum and Vaccine Limited. Okay, and again, this is the animal bite exposure register. Just look at this. This is the animal bite exposure register where these cases are written, and the data are filled in reporting month, one for 1 month. So how many cases you have to give the number, you have to give the date, type of patient, name, age, sex, all of this, site of bite, animal biting, which species have bitten, category, what is the category where the incident took place, to write, and you know, if adequate washing was done, you have to tick on it. If rabies immunoglobulin was given, you have to tick on it. ARV, previous history, biting animals after 10 days. This is obsolete now, but sometimes used. Okay, and remarks. This is the thing to be maintained by health facility providing treatment to animal bite cases. Okay, so they have to maintain this register. And post exposure prophylaxis treatment card. Okay, treatment card is provided to the patient who are coming for the bite, and here there's ticking and all of this data are given. Okay, and this is not much important. Nothing is there. This is the suspect case. Case definition for human rabies. Case definition. Okay, suspect case. Death of a human with history of dog bite few weeks or months preceding death. Okay, few weeks or months preceding death is the dog bite. Okay, this is a suspect case. Probable case to be reported in format by medical officer. A suspected animal human case plus history of exposure to a rabid animal. Okay, a rabid animal. These are the things. What is the characteristics of a rabid animal? Unprovoked aggression, okay, hypersalivation, paralysis, lethargy, abnormal vocalization, diurnal activity of nocturnal species. Okay, all of these abnormal findings are seen in a rabid animal. The laboratory confirmed case, a suspect or probable human case, that is laboratory confirmed. Okay, laboratory confirmation is done for the lab diagnosis. Okay, lab diagnosis of rabies. Here, some things are written. Detection of rabies viral antigen by DA, direct fluorescence antibody test. Okay, direct fluorescence antibody test (DFA) or by ELISA. Okay, rabies viral antigen by ELISA. Preferable brain tissue is collected. If the person has died, then this type of negri bodies, negri bodies are intracellular inclusion bodies in rabies, negri bodies. Detection of fat on skin biopsy. Fat means not that fat. Okay, fluorescent antibody test. Detection by fat on skin biopsy. Fat positive after inoculation of brain tissue. Detectable rabies neutralizing antibody in CSF or serum. Okay, viral nucleic acids on PCR. These all things are there. Okay, this is a thing. Dietary restrictions. There are no dietary restrictions to be given. So if you are a doctor, then you don't need to tell the patient that don't eat potatoes, don't eat tomatoes, and anything like that. Okay. Excessive alcohol should be discouraged. Of course, it is a routine practice. Alcohol smoking have to discourage the patient at any cost. Right. Vaccinated dog can also transmit rabies. All of this thing are there. Okay. Possibility of failure. This thing is there. Pregnant women, it's a potentially fatal disease, so pregnancy is not a contraindication. Consuming meat from a rabid animal is strongly discouraged. Although no cases are reported, but various other infections can transmit. Okay, so rabid animal, eating a rabid animal, anything like that, or cooking cooked meat also do not transmit rabies, but you can't just ignore it and tell the patient that you have to eat or something. The patient is sometimes like, let me take revenge on the animal. He bit me, I will bite him, cook him, fry him, nothing else. Don't do that. Okay. How to protect the pet dog from getting rabies? Not to vaccinate the animal. Rat or rodent bite. Rabies is not transmitted by domestic rats. Very important. Not transmitted by domestic rats. Not necessary. Okay. If you can consult your physician in cases. Okay. Organ transplanted from rabies infected donor can transmit the organ to organ infection to organ recipient. It's very important. So organ transplantation, rabies must be taken into consultation. Okay. These are the things. Adverse effects are very mild. It's a very least reactogenic vaccine ever available. Okay. These are the things. So protocol. This is the protocol which are pasted on your thing. So look at the protocol. No prophylaxis. Okay. Category 1, touching or feeding infected animal, licks on intact skin. No prophylaxis needed. Only washing under running water. Category 2, nibbling of uncovered skin. Okay, nibbling of uncovered skin, minor scratches. If previously not immunized, you have to give your SN or modified thyroid cross 03728 SN regimen or 5 doses 11111. That is the SN regimen. This is modified thyroid cross. Rig is not indicated. 5 doses infiltrate wound with rig as soon as possible. Okay, you have to give. Maximum dose of H rig is 20 international unit per kg body weight, while that of E rig is 40 international unit per kg body weight. Okay, and if it is previously immunized, then you have to wash the area. Of course, washing is compulsory. Then 2 doses. This is the with prophylaxis, re-exposure. Re-exposure means re-exposure. I told you, re-exposure means 0 and 3. 0 and 3, 2 doses only given. 0 and 3, intramuscular or intradermal. This is the re-exposure prophylaxis. Okay, and immunocompromised, you have to give IM dose. Okay, and again, the category 3 is basically multiple transdermal bites on scratches, licks on broken skin, contamination with saliva. If you previously unimmunized, then you have to give the re-exposure prophylaxis. And if it's previously immunized, okay, previously immunized, if in doubt, if the patient says that I doubt if I have been immunized or not, I have forgotten that I have taken vaccine or so what, okay, if the patient is like that, just don't waste your time and give as a new case. It is not immunized, that is the you have to give the post exposure prophylaxis in this case. And if category 3 bite previously non-immunized, then you have to wash, then you have to give the modified thigh or SN regimen. Okay, and you have to give the rig. Do not give rig beyond 7th day. Okay, and after the first vaccine dose, you have to give the rig. And immunocompromised IM dose is required. IM route is required. Okay. Intramuscular and intradermal human rabies vaccination site, do not inject in gluteal region, deltoid muscles for adults and children. Children basically anterolateral thigh for small children and this infants. Then washing is immediate with 15 minutes soap, water, and disinfectant. Okay, rabies is 100% fatal but preventable disease. Okay, rabbit can be, just do not apply this and do dressing. All consult doctor, vaccinate your pets, everything. And that's all in today's lecture. I discussed rabies with you in complete detail. I have not discussed the microbiological aspects of rabies because that was not our topic. Okay, that was not our topic. Our topic was basically uh, guidelines of rabies. Okay, guidelines of rabies. So basically, we discussed all the guidelines which are there, and we read the whole guidelines of rabies. We completed the National Center of Disease Control, the NDCC guidelines, and NRCP guidelines, the Rabies Control Program guidelines, and Rabies Exposure Prophylaxis guidelines. Okay, so this is the guideline which is available in the internet, and this is the most recent guideline. When new guideline comes, I'll make another video with the changes in the guidelines. Okay, so that's all. That's all for today. I hope you enjoyed the lecture. Thank you and bye bye.